In recent years, our healthcare system has been the subject of much debate and policy change. With the enactment of the Patient Protection and Affordable Care Act, much of what is known about the healthcare system is changing. This has been one of the most drastic departures from the traditional healthcare system that we have had. Why was there a need to change the healthcare system? How did we get to a place where healthcare reform and restructuring was needed? To answer these questions, we must look back to our history to see how our political system, policies, programs, and values have shaped our modern healthcare system leading up to the PPACA. Our government was created with the division of powers between the central government and states known as dual federalism. While the system ensures that the central government would not abuse its power over the states, in order for a law to pass, both houses of Congress must vote and pass it before the president approves it. Compromise in legislation is inherent in this type of system, and it has been the compromises on important healthcare policies that furthered the creation of the healthcare system. In addition to the structure of our government, the healthcare system was shaped by the values of the American people. These core values include individualism, fairness and equality, and liberty. Liberty is, was, and will continue to be the ethical justification for healthcare reform in the healthcare system. Liberty encompasses privacy, choice, civil rights, and individuality. Americans revere freedom of choice in selecting their physician and healthcare plan. It was with these values and the governmental system where key legislative acts were born and shaped the healthcare future. The American Association for Labor Legislation was the first to propose an insurance program that would provide sick pay, medical and maternity coverage for women and wives of men, and a small death benefit. But there were many opposed to this program, especially employers who were to be the primary payers. To encourage employers to take part in an employer-based health insurance program, public policy choices such as the Revenue Act of 1942 and the National War Labor Board ruling in 1943 stated that employee benefit plans would be tax deductible. The American Medical Association, a powerful group of physicians, played a major role in the maintenance of the employer-based health insurance system. The AMA vehemently opposed and prevented the passing of any bill that intended to implement national health insurance, such as the 1943 Wagner-Murray-Dingle Bill. Disapproval stemmed from the group's fear that increased government control would eliminate their autonomy and power. With relentless opposition to and repeated failure of reform proposals, an employer-based health insurance system remained intact and continued to grow. Regrettably, this system created a huge gap between the insured and the uninsured. Employer-based healthcare left millions of people uninsured for a variety of reasons, including unemployment and job loss, being self-employed, some employers not offering a health coverage plan, and even if they did, some people simply could not afford to pay for it. Many companies minimized benefits because they either could not or did not want to cover premium expenses. National health insurance could have resolved these issues, but Americans desired neither increased taxes nor increased government involvement. The employer-based health insurance system minimized the government's role and allowed citizens to retain individualism, but it did so at the expense of inadequate coverage and inadequate care. In 1965, Medicare and Medicaid were enacted to ensure the elderly and low-income populations had health care coverage. Under Medicare, the federal government would provide health insurance for Americans aged 65 and older, along with individuals under 65 years old with certain disabilities and end-stage renal disease. Medicare Part A has no premiums and covers inpatient care and hospitalization, which included nursing facility care, hospice care, and home health care. Medicare Part B covers doctor visits, outpatient care expenses, medical equipment, and some preventative services. Along with a monthly premium, each person is required to pay part of the cost of medical services, including the deductible and co-payments for Part B. Medicare Advantage Part C combines Part A and B in a government-approved private plan offered by an insurance company. Enrollees can also buy a separate prescription plan, Medicare Part D, which is offered through a private insurer. Medicare Advantage and Part D fulfilled Americans' value of individualism and personal choice by allowing each individual to personalize their plan according to their needs. Unfortunately, there have been issues with fraud and abuse in the Medicare program, specifically with billing and payments. In 2004, the U.S. negotiated $605 million in settlements involving Medicare and Medicaid programs, and in 2005, the Center for Medicare and Medicaid Services collected around $1.5 billion in fraud settlements. As a response, in 2011, the CMS announced a new bundled payment system to expand from per diem cost-based system to a prospective payment system. Under the bundled system, hospitals were paid a flat rate for all services for a particular illness, which forced them to create organized and effective care, potentially lowering costs and improving care quality. In addition to a medical coverage system for the elderly, the government also created Medicaid, a state and federally run system that provides medical coverage to low-income Americans. Medicaid was passed into law in 1965 as one of the Social Security amendments. Since the enactment of Medicaid, issues between the states and the federal government over eligibility and expansion have occurred. Parameters for eligibility and benefits offered are determined at the federal level, and it is up to the states to carry out the law in each of their states. This gives states the freedom to vary eligibility requirements, sometimes limiting eligibility and paying healthcare providers such a low fee that many refuse to see Medicaid patients. Furthermore, Medicaid has been a long-time budgetary concern for the federal and state governments who share expenses of the program. Republicans and Democrats have criticized Medicaid and the financing of the program. Republicans proposed to cap federal funding while giving states more flexibility, and Democrats defended the program and the funding it currently provides. This debate over budget and funding persists as healthcare expenses continue to rise with both sides on opposite ends of the spectrum. The shared power of operating Medicaid will always present a challenge to keep costs down and to give adequate care to those in need. However, with Medicaid, many low-income pregnant women, children, and disabled citizens have access to the care they need. After implementing Medicare and Medicaid and the rise of employer-based health insurance, more citizens had access to medical care. With this influx, it was realized that federal law was necessary to regulate employee benefits by ensuring that employers explain the pension plan offered and follow through on providing those benefits. To ensure this, the Employee Retirement Income Security Act was passed in 1974 with intentions of providing security and equity to the retirement income of private sector employees. The enactment of ERISA was intended to be congruent with American values of fairness and liberty in terms of being guaranteed the rights to their benefits. ERISA was supposed to provide national uniform standards in healthcare reform. However, despite ERISA's preemption clause to limit states' power over regulation of employee benefit plans, the Act still managed to allow wiggle room for the individual states to make provisions of their own. Ambiguous authority, and therefore improper regulation of healthcare delivery, called for additional legislation to create consistency and make amends. In 1996, the Health Insurance Portability and Accountability Act was implemented to establish structure and consistency in the health insurance market. To do so, the Act allowed the government to take a more active role in areas in which states have been dominant. HIPAA also added further protections to the COBRA Act of 1985. Now, not only were hospitals unable to turn away the uninsured, but insurance companies faced greater restrictions in denying coverage to people with pre-existing illnesses. The portability section of HIPAA protects citizens from losing health insurance when they switch jobs. The accountability portion contains laws that enforce penalties on providers who overbill insurance companies. Most importantly, the privacy rule of HIPAA established standards and security protocols for access to and sharing of citizens' healthcare information. Unfortunately, the privacy rule only applies to covered entities, those that had established an electronic database containing patients' healthcare information prior to the enactment of HIPAA. This mishap allowed for breaches of certain citizens' privacy, requiring further legislation in attempts to resolve the issue. To strengthen past acts on patient privacy, the HITECH Act was ratified on February 17, 2009, as part of the American Recovery and Reinvestment Act of 2009 to deliver high-quality healthcare through computer technology. HITECH unionized standards that enable effective information collection and exchange in clinical use, meanwhile building the infrastructure for health information technology. HITECH also allows providers to exchange clinical data with other providers. Unfortunately, sometimes computerized medical records and patient information can be exchanged with other non-medical related electronic data systems, such as insurers and data aggregators. Luckily, HITECH requires health providers to notify their patients when and if their information is breached by a party who should not have access to them. All in all, the HITECH Act was put into place to ensure that patients' privacy, security, and quality care are met. Legislation and the U.S. approach to healthcare has been structured around American values of personal choice, fairness, equality, and privacy, but in attempts to fulfill those, the system has failed us in a variety of aspects. While multiple acts were implemented with good intentions of structuring the U.S. healthcare system, time has proven that in many ways they have done just the opposite. Federal legislation has resulted in increased costs of U.S. healthcare and premiums and led to higher rates of people without coverage. The healthcare system faces significant limitations in terms of change. First, due to federalism and the compromises that must accompany legislative decisions. Secondly, Americans' historical and current distrust of a strong central government has continuously prevented substantial deviation from the status quo. The influence of federal legislation and American ideals has both shaped and enabled this system to stay intact. This has allowed uninsured rates and health care expenditures to soar, resulted in endless financial burden for citizens, and promoted inequitable coverage and care in general.